And I'm very happy and honored to give the presentation tonight. So I'm going to start with this slide. And can everyone see my the cross section of this tooth, this big blue tooth? I just want to make sure that you can see it. Is that yes? Okay. So this is finite element analysis shown of a standard cavity preparation. Most dental schools in most countries are creating composite preparations that have parallel walls. And the problem is, even though we have adhesive materials, when you load up a tooth with two cusps, especially a cusp that's tall on the palatal, this is a maxillary first molar, as the tooth bends and experiences strain, the stress can be unevenly distributed across the tooth and the tooth composite interface. And so the two things that when structural engineers looked at the way that we're doing restorations, and we worked with Dr. Alex Flock, the two things that we have to eliminate if we want to keep a tooth from breaking is that number one, we have to not have deep occlusal grooves in our posteriors. So you're going to notice that with the restorations that you see with me, that hopefully will last for 20 or 30 or 40 years, we do not put deep grooves in the occlusal because that's a structural weakness according to the engineer. The second thing that we're going to do, instead of having parallel walls like this, we have to horizontalize, in this case, horizontalize the preparation so that we have 2 millimeters of horizontal enamel so that when we hit the tooth is put into compression instead of tension. So let me get right into the difference. When we do a traditional cavity preparation like you see on the left, as the tooth bends, composite over time will not strengthen the tooth if we have a deep groove, or in this case, if we have vertical wall preparations. So this is a case done by Dr. Regalado. We'll show you the preparation. He has horizontalized the prep. It's called the calla lily prep. It's a beautiful flower. And so when you strike against this tooth, the cusps literally come together. So on this tooth, even with adhesion, because it's the normal cavity prep, it's poorly engineered. Now I understand. We've been cutting this prep for 100 years. But these teeth have been breaking for 100 years. With BioClear, we can put the tooth into compression for the first time. But the big change is that with BioClear, instead of the composite going inside the tooth, BioClear goes literally around it. And because of that, the modern cavity preparation, I know I like to use my hands like I'm leading the music. We can put this tooth into compression. So we can take a patient who has severe biting pain, and the pain goes away instantly. So let's take a look at the finite element analysis that supports the BioClear method. This was done at the University of Minnesota. So here is the study. And so when we load the tooth, with a standard cavity preparation that is taught in most dental schools, the cusps go out. And then with BioClear, the cusps can go in. And so let me go ahead and we'll run the video. On the left, you see the cusps going out, 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 each time you bite on the tooth. And if there's not a good bridge, you have a lot of bridges in Seoul, okay? You need a bridge or buccal to lingual that will keep the tooth put together. And then on the right, this is the card class one, that does not have a deep groove, and the composite goes over the cusp tips like so, or to the cusp tip, I'm sorry. So let's go ahead and look at this with higher magnification. The tooth on the left is a standard cavity preparation, and you can see as it cycles, the cusps go out, and over time the tooth can break. With the Clark Class 1 and the Clark Class 2, we have a beautiful bridge from buccal to lingual, and because of the resilience of composite, for the first time in history, You can strengthen a tooth with multiple cusps and prevent fracturing. Now, in the United States and in Korea, dentists are in love with crowns. We think of crowns as very permanent, but a crown does a lot of damage to the tooth. We understand that, and now with BioClear, we can do something that can last like a crown, but without all of the damage. So we're creating patient awareness that BioClear for the patient is better than a crown in many ways. Now, we still need crowns, but I'm going to show you some of how popular BioClear has gotten in the United States. And it's only a matter of time before patients will start asking for BioClear in Korea. Because when we do a crown on a tooth, we have to take away 76% of the tooth, and there's a 20% chance after a root canal, or excuse me, a 20% chance after we do a crown that the tooth will need a root canal. You know, not surprisingly, I have many, many dentists that come to me to restore their teeth instead of crowns. They come from all over. This is a row of teeth, 10 years postoperatively, actually it's been 20 years, of the callus preparation and the cuspal overlay to put the tooth into compression. On the bottom is a 6-year post-op of a black triangle case. So today, the BioClear method, we can expect very long, very strong outcomes, but everything has to change. So here's the BioClear method. Number one, we have to disclose and blast to remove biofilm, because when we go around the tooth and we don't cut the tooth, our composite will bond to uncut surfaces. So we disclose and we blast to remove biofilm. I'll show you what that looks like. The next thing is modern cavity preparations. We no longer cut mechanical retention, but we have to put the tooth into compression with the infinity edge and a horizontalized preparation. I'll explain that. Now, I know for some of you this is a lot of new information, but it's important to paint a picture of the massive change that the BioClear method makes, but we need all the elements. The next thing is the matrix. The BioClear matrix is beautiful and strong and more curved than the tooth. We have to have the matrix come in with an angle of incidence that's about 15 to 45 degrees. When the matrix comes in, I'll show you this, with angle, we can injection mold to the infinity edge. Now, if the matrix is parallel to the tooth, it doesn't work. So most matrices, metal matrices, flat mylar, you don't have the infinity edge because you have to have an angle. So every BioClear matrix is more curved than the tooth. The next thing is we injection mold the composite. It's much easier to inject the composite when you heat the flowable and we heat the paste. We're no longer layering. Layering is old. Layering is the past. The future is injection molded monolithic composite. The Boeing airplane and the new Airbus airplane are made from monolithic composite, not metal. So monolithic composite can be very strong. The last thing is, we taught this at the Learning Center in Seoul, and we had, I think, 13 doctors come. The Rockstar polish is so beautiful. It creates the beautiful, shiny, specular highlights that can demonstrate the gentle anatomy of the BioClear tooth. So those are the 5 pillars of BioClear. Now let's go back to 2007. There's a bias. People said, oh, we have to layer everything. Let's talk about layering. This is a case where Dr. Richard Price, a well-known expert in Canada, took a doctor and put in 1, 2, 3, 4 layers, because that's what was used to be taught, and it still is taught in most dental schools. Every time you layer and put composite on composite with your hand, it creates weaknesses. This is about 60 or 70% weaker than monolithic. The same doctor injection molded this class 2. Now, we have to have a high depth of cure composite, 5 millimeters depth of cure. Currently we're using Filtech 1, which has 5 millimeters depth of cure if we have a clear matrix, and if we do what's called 3-point light curing. We'll show you that. Here's doctor number 2. You can see the 4 layers. 1, 2, 3, 4. Layering is slower, it's weaker, it's not as aesthetic as monolithic composite. It's the past. And for some of you, you're probably okay, because you're already doing this. Others have been taught that layering is better. But let me tell you, the science tells us that layering is not better. So the belief is that layering will mitigate polymerization shrinkage stress and stop microleakage. That is completely untrue. Here are 8 studies that will demonstrate that layering does not mitigate polymerization shrinkage stress. And almost every school teaches this. It's bad science. There was maybe 1 study that validated layering. There's 8 studies that says layering doesn't work. What is polymerization shrinkage stress? This was published in the Journal of the American Dental Association. Here's a cavity preparation, an old-fashioned cavity preparation. When the composite is cured, the cusps get pulled together like this. You can measure this. It's cuspal deflection. Well, in this study, they layered it 1, 2, 3, 4 different ways. It didn't matter, because at the end of the procedure, the cusps got pulled in. So layering does not mitigate polymerization shrinkage stress. The best way to mitigate polymerization shrinkage stress in a posterior is to change the cavity preparation to the Clark class tube and allow the composite to go around the tooth. It hugs the tooth like this, and as it shrinks, you don't see the problems with normal polymerization shrinkage stress. However, in normal dentistry, I see it everywhere I go. You have a failure of composite. They really don't look very good. And so many dentists say, composite is temporary. I'm going to do crowns everywhere. A crown is very hard on the tooth. So we're at a crossroads in dentistry. Are we going to do the easy thing and do a crown? Or are we going to do something better? Are we all going to retrain ourselves to give us the kind of dentistry that we would want in our own mouths? And it's really exciting for me to be with you tonight. I was just lecturing to 200 periodontists about 4 hours ago here in San Diego about closing black triangles with the Baker method. So it is, it's a really wonderful opportunity to share this great gift to Baker. Let's talk about the modern class 2. So in most dental schools, we teach mechanical retention and resistance, but this leads to tooth fracture. And then we have these what we call slot press or box press that tend to fall out because they don't have mechanical lock and they have poor C factor. And so even though this cavity preparation is less destructive than the one on the left, they're both bad. So this is the Clark Class 2. We're going to demonstrate this now. So the Clark Class 2, we have several videos that our wonderful dealer in China, Mr. Cho and the captain have a whole library of videos. We can show you how to cut this new cavity preparation, but we have to horizontalize the preparation. So right here, where the cusp hits the tooth, it is horizontalized. Now, when I went to dental school a long time ago, we did gold dentistry. And when we did our gold, we would flare the gold like this, and very long lasting. So it's a very different kind of cavity prep. So this is what most of the world does for a class 2, and most of them were leaking. That's when the composite goes in the tooth. With BioClear, we go around the tooth. Now, you have to follow the 5 principles that we talked about, but it's a very different outcome. So there's a great comparison. Now, I'm looking forward to everyone with your questions as we get toward the coffee break. So just keep saving those questions. So when we look at extracted teeth, we have cavitation, which is a hole in the tooth, and we have aprismatic enamel. They're 2 different things. Because of fluoride, and also because of all of the sodas and all the sugars in the modern diet, we can see a lot of aprismatic enamel, but then we have a small cavitation. So we really need to redesign our Our restoration is based off of modern adhesion and modern carriology. So you can see all these areas have a lot of aprismatic enamel, but then a small cavitation. Here's the question. In dental schools in America, they teach a very small box prep to preserve tooth structure, but then they put the margin in a place where we get disease. With the Clark class 2 and with gold, we flare the wall in a minimally invasive way to put our tooth restoration interface on the outside of the tooth where it's going to be much more disease resistant. So let's put it all together with a case study of a failed composite. This composite was done by an American dentist 2 years ago. Just 2 years ago. And so this is the Evolve all-in-one kit. It has everything that we're going to need. We'll talk about the matrix identicator, the adjustable push-pull, which is incredibly important instrument to get tight contact with BioClear. The new twin ring universal is the most powerful separator in dentistry. We need all of those things to get a very strong contact. So let's go ahead and go through this. Let's go ahead and go through the case study. So there it is. So we have all these problems with traditional parallel wall, or what we call a slot preparation in the United States. So the problem is if you extend the slot preparation to eliminate all of the aprismatic enamel, you destroy the tooth. Now the cusps are going to break. So it's bad if you make it small, and it's bad if you make it big. So the preparation needs to change. So now we're taking a different view. We've got my rubber dam in place, and you can see that it was a bad restoration from the beginning. You cannot put your margin on aprismatic enamel. You're leading decay if you do that. You get no seal. So I can pretty much guarantee you that the doctor who did this with his margin on aprismatic enamel. So the first step with BioClear is we're going to use an disclosing solution, and then we're going to blast. I will blast the entire tooth. This is aluminum trihydroxide. It is significantly softer than aluminum oxide. Aluminum oxide we use to sandblast crowns or to make a hole in the tooth. Aluminum trihydroxide is the same hardness to dentins. So this will not cut it out, but it removes the biofilm and it removes the protein pellicle temporarily. So we're going to go and blast pretty much most of the tooth. That's what it looks like. And now we can see the sort of the fundamental flaw of traditional box preps. So pre-wedging is one of the most, well, they're all important steps. Pre-wedging, we put the wedge in before we cut the class 2. And you can see that in this case, this is a very, very tight space. We have root proximity. These diamond wedges, I love these things. This wedge will fit almost anywhere. If you try to put a standard wedge between these two teeth, it will never fit. So the wedge goes in, and then the diamond opens up like this. Now, the diamond does not open up because the tooth is very wide. We have a long wedge. So your clue is the wedge long enough as the diamond is open. If the diamond is closed, then you'll need to use the longer wedge, which we use about 20% of the time. Now, I put a pre-wedge on the mesial because I was looking for decay. One of the beautiful things about putting a wedge in before we prep is we see more. And if we can see well, we can do well. And a lot of you use magnification. Some of you use microscopes. This is just as important as using loops, the pre-wedging. So we see the problems with traditional, old-fashioned cat class 2s. There's the decay. This is a new bird that we'll have with BioClear. It's called the calloli fissurotomy. That will be available soon. That opens up the groove in a less invasive way. And then we take a little diamond and we'll sweep the contact. You can come from the occlusal. You can come from the inside to the outside, or from the outside to the inside. One of the things that we really enjoyed at the certification class, which we continue to teach in Seoul, is the bird movements, how to straighten your hands to cut these new cavity preparations. You can talk to anyone, and we have one of our doctors that will be lecturing later about his journey cutting the new class 2. So we flared the cavity walls. We have a couple of things left to do, but does anyone see anything suspicious here? Is Dr. Clark done, or is there a problem? Is there a problem? Let's look right here. Yeah, there's caries at the DEJ and a prismatic enamel. And the problem is most dentists in America are leaving this because they're not looking for it. You cut a box prep, you can't even see it. And the schools are not really teaching the most important thing, which is to remove all of the caries at the dental enamel junction. So at the junction between the dentin and enamel, we call it the DEJ. I used to know what that is in Korean, but it's the junction between the dentin and enamel. That's an area where cavities start. It's like cancer. It has to be removed. Now, in the modern world, we can do selective caries removal and leave caries here, but never at the DEJ. So I'm going to finish my prep, remove that there, but then I'll flare the cavity wall a little bit more. We always smooth the neighboring tooth with the SawFlex XT disc in the inverted position. You have to have the disc backwards. You can see that the disc has the abrasive facing toward the hands. All of the rules of biocare are pretty strict. And so we take the disc to flatten and make the neighboring tooth perfectly smooth. I would blast the inside of the tooth again. Now we're ready. It's a very different shape. You have about 2 millimeters of beveled enamel that you can't see very effectively here, but that puts the tooth into compression, like we showed you in the diagram. There's another view. This is the matrix height indicator. It's a very important tool. I'm going to drop this in. What is my reference for the depth of cure, and what is my reference for the matrix height? This instrument does 2 jobs. Now, I think you have stoplights in Korea that are like the ones in America. We have green, which is go, yellow, which is caution, and red is stop. So, this cavity preparation is only 4 millimeters deep. So in the class 2, if you are in the green or yellow zone, that is a go. You do not have to layer. Now, if the prep was, let's say, 6 millimeters deep, and my reference is the neighboring tooth, that will need to layer. Do 1 layer on the gingival, and then we injection mold. We don't need layering here. The next reference is, how tall should my matrix be? In today's work, I'm using a little bit taller matrices because we're wrapping the tooth. So I want my matrix to wrap all the way to the cusp tip. So the matrix would need to be at least 6 millimeters tall, but we're going to push on the matrix as hard as we can for 10 seconds to create a perfect gingival seal. So I will need a 7 millimeter matrix because the matrix is going to go 1 millimeter at least past the edge of the preparation. Now, I know it's hard to listen to me in English. I wish I spoke Korean, but we'll have some translation toward the end. So the height of the cusp is 6 millimeters, so the matrix that I'm going to be using will be a 7. And right now the matrix is a little bit too high, so we're going to push on the matrix as hard as we can. And the matrix will go into the sulcus, and then it will go into the long junction epithelium, which creates a perfect seal. Whether it's a class 2 or a black triangle, it is a perfect seal. And now I know this is crazy, but the wedge does not seal the gingival margin when you injection mold. You have to have an anatomic matrix that's clear and strong and more curved than the tooth. So here's a cross section of the tooth, and we're going to take the matrix and we're going to drive it all the way almost to the ligament. This will be 1 to 2 millimeters deeper than you would ever do a crown margin. And I just got done speaking to 200 periodontists, and they all said, yes, this is good, this is okay. You can do this because this is so smooth. It's like the natural enamel dentin junction, cementum enamel junction in the mouth. So The matrix is always going to go a little bit deeper. We don't see bleeding because of the technique that we use, and that's how we get such beautiful margins with the class 2 or with the black triangle. So once again, the matrix is going to go into the long junctional epithelium. It has little suction cups, like an octopus. And it pulls those off, and it goes right near the ligament. Okay, it's a beautiful seal. So I'm going to push as hard as I can for 10 seconds. And the matrix goes deep, and then while you're pushing, you put the wedge in, because the wedge will lock the matrix in deep. Now we're going to practice with our adjustable push-pull instrument. We always make the adjustments, and then we look to practice, to rehearse, so that when we do our spot weld push-pull technique, we know the proper angle and the proper opening of the push-pull instrument. So I'm practicing, there's 2 different ends. This is the smaller end. So now we're going to acid etch. And remember, the edge of the restoration is dictated, is formed by the edge of the matrix. So wherever the matrix goes, that will be your restoration. So for a lot of class 2s, you will cover the entire mesial or distal half of the tooth. Or if it's an MOD, the whole tooth. So we acid etch to the edge of the matrix. We're going to massage the adhesive into dentin tubules for 20 seconds. And then before we cure the dentin, we're going to take a little bit of cold flowable composite. You do it every time. You'll take some cold flowable composite here, and then you can make an extra little, we call it a weld, and that will grab the enamel, that grabs the matrix, and then I have a little container, like a cup, to hold the matrix. And then we push as hard as we can with the push-pull instrument, which you see here, and then we cure the buttons. We cure this little weld of the cold flowable, and then the separator comes off, and then we have to do 3-point light curing. I will show you a video again of the procedure, and then the Rockstar polish. There's the components of the Rockstar polish. This is the magic mix. In a disposable cup, it's the world's best pre-polisher. And then the Rockstar polish cup, these are diamond impregnated, and that's what we see. There's the beautiful biocurve shape of the composite going around the tooth. And you can see that we've grown the contacts significantly. Large contacts are what we need in the future. Little point contacts, they're not good. We want broad contacts. So we've adapted this matrix, we put a lot of energy into it. You can see that there's a tremendous difference between old-fashioned composite that goes in the tooth to bioclear that goes around. So here's a similar case, pre-op, post-op, and 3-year follow-up. So people say, David, the composite is very thin. Well, because it's in compression, there's no minimum thickness of composite over enamel in compression. You can see a little wear facet here 3 years later. But because the walls have been horizontalized and they're in compression, with intention, we see beautiful wear because most modern composites wear at the same rate as enamel. All right. Just a minute, I need to just a moment. Let me make sure that, yes, I gotta make sure I've got the boundary now here. All right, now, I want to make sure that, are we still okay? Can everyone still hear me? Mr. Joe, are we okay? I had to change my charger. I want to make sure that everyone can hear me.
Yes, we can all hear you.
We're all okay?
Yes.
Okay, thank you. All right, sorry about that. Okay, so are all separators equal? Because the biocure matrix is stiff and strong, you need a powerful separator. So there are a lot of separators out there that are not really very good. So this is the ultra-dent separator. We stretched it one time to 20 millimeters, and look what happened. It lost most of its power. So most of these separators don't have a very good design. They have the wrong kind of metal. When the separator stretches out, it undergoes plastic deformation. It loses most of its power. So here's a triodent that's been stretched multiple times. It's losing its power because it doesn't have very good design. Here's the twin ring universal. We stretched it 20 times. The metal will not fatigue because we have it engineered very precisely to avoid plastic deformation. And as long as you don't stretch it past 20 millimeters, the metal will never wear out because it has dual springs. So we're going to talk about 3 ways to get great contacts. Number 1, we need power. Number 2, we need strategy, which we can talk about in a different lecture. Number 3, we need technique. The technique is the small bug push-pull technique to make sure that the matrix is very tight and very approximated to the neighboring tooth. All right, so this is an Instron test studying different separators. So they're going to put the twin ring universal in first. You're going to notice it goes to about 22 newtons, but you always take a separator and push it apically. So then we're going to take a look at the Garrison. And he gets up to about 18 newtons. And then we'll go ahead and take a look at the treated yellow. Now we get up to about 19 newtons. And then the treated green, we get up to about 15 newtons. This isn't really the first study of its kind to really measure with an Instron how much separation pressure that the separators create. And remember, these were all used separators because some of them are strong once or twice. But you need to use the separator 100 times. And so the twin ring universal over time was to keep its strength, and all these other separators have a lot less power once they've been used for a while. So one of the things about Baiclear is the mylar is a little bit thicker than a metal matrix. So we have to have power with all of these things that we do to create great contact. So the twin ring universal is a big part of that. All right, so we've got about another, I think, 10 minutes before break time. So let's talk about all the evolved matrices. We have Baiclear is color-coded for emergence profile, but because the premolar is just one shape, we gave the premolar the black color. So the premolar is black, and then we have 2 basic curvatures for molars. Very aggressive curvature with the blue, and then the orange is fairly flat. We'll use that for root proximity cases where there's just not enough room interproximally for a lot of emergence profile. Most of the time, you're going to want a lot of emergence profile. So these are the premolar matrices. They go all the way to 10 millimeters. The blue evolve goes up to 9 millimeters. And then the orange has 3 different sizes. We don't use this matrix as often, so we just have the 3 sizes. And then if you need, say, an 8 millimeter, you can just trim the chisel of the 9. So those are the different matrices that we have for posterior teeth. And so this is the adjustable push-pull, and I'm hoping that you can hear the sound. So will you please let me know if you can hear the sound from the video when I play this? If not, I'll have to narrate it.
Congratulations.
Can you hear this?
Let me explain how the keeper works.
Yes, we can hear you.
I want to send the spider button down to the smallest position at 4.5. This would be appropriate for the premolar or black evolved matrix.
Can you hear me talking in the video or not?
Please still talk, yes. We can hear you, yes.
소리 크게.
Okay, great.
For most molars using the blue evolved matrix, use the setting of 5 to 6. For wide molars using the orange evolved matrix, use the setting of 7 to 8. For smaller cavity operations, we will need to showed several clinical indications on when to use these instruments. Let's start with the premolar. For premolars, we are going to be around the 4.5 millimeter. This corresponds roughly to the outside dimension between the outside of these two little hands. So, when we're doing the spot weld push-pull technique, which you can see in a separate video, with the two little dots of cold flow composite here and here. And then before we line through the adhesive, we're going to go in and put the push-pull instrument in to parallel the neighboring tooth. So let's take a lateral view of this. The hands of the push-pull instrument should be parallel to the contact area of the neighboring tooth. To accomplish this, we don't want the handle to be too low or too high. It's a good idea to practice before you begin to do the restoration. So let's zoom in and watch how beautifully they were able to adapt and approximate the matrix with the new adjustable push-pull instrument by BioClear. Let's go in.
So you can have time to watch the rest of that later. We make adjustments on how wide the hands are based on if we're molar or premolar, blue or orange. But in the interest of time, you can watch the rest of the video later. This is another important feature for the twin ring universal. I want to review this very quickly. We completely redesigned the twin ring universal so that it would not fall off with short teeth or teeth without an undercut. So I'll play this video very
Let's
quickly.
take a look at the new twin ring universal with its incredible ability to stay put on its tooth or undercuts or short teeth. This is a model that I took a few years ago when we were doing a class 2 on my nephew, and we could not get the separator to stay on the teeth. So this is a great model because it has very cordial of the teeth, and yet the twin universal has the ability to stay in place. Let's compare that with a standard separator. This is the Garrison. Try to put it on this area. It's an exercise in frustration. Try one more time. When this slips on a patient, it's incredibly stressful and even dangerous.
All right. So this is another video that's on the library, but this goes over the entire procedure from start to finish. So I want to show this video, and I just want to make sure that you are hearing the video, you're hearing the sound from this, correct, everyone?
Yes, okay.
Yes. Yes, okay.
Welcome to the BioClear step-by-step guide for the injection mold in Class 2. Finish the Class 2 preparation and remove the pre-wedge. Remove loose enamel rods and hard deposits like calculus with a Comet diamond strip. Blast both the inside and the outside of the tube using aluminum trihydroxide in the BioClear blaster. Optimize the neighboring contact with the disc. We like to use the 3M Softflex XT course disc in the inverted position. Measure the cavity depth guide using the Evolve Matrix Height Indicator and Go No-Go probe. You can go ahead and measure inside the cavity prep, and then go ahead and measure outside of the cavity preparation to assess where the gingival attachment is. The BioClear Evolve Matrix is rugged and will withstand heavy seating pressure. Trap the tab of the matrix against the neighboring marks on the ridge during insertion to keep the matrix fully seated and stable. Push as hard as you can for 5 seconds to fully seat the matrix. The tab should be centered as shown. Continue to push on the matrix while you insert the diamond wedge. Push the wedge as far as you can with the back of the cotton pliers once it's been inserted. Place the twin ring universal. The twin ring has 4 hands that will straddle the wedge. Once the twin ring is placed, gently rock the twin ring abruptly like a rubber dam clamp to assure full seating and full power. Place the phosphoric acid etchant. Make sure to inject acid etch all the way to the edge of the matrix, which is the infinity edge area. Then etch for 20 seconds, rinse and dry. Place and massage the 3M Scotch-Bond Universal Plus adhesive into the dim tubular areas. You will do this for 20 seconds. Air thin the adhesive. Place 2 beads of room temperature 3M Flowtech Bulk Flow Restorative 2 mm diameter inside, over, and outside at the corner of the matrix near the cusp tips.
좀 이따가
The push-pull instrument is placed
시작하고